what do I want you to focus on for day 20 and 21? I'm going to couple 2 days together because it makes a lot more sense. So day 20 and 21, I really want you to be pulling together everything that you've gone through so far. So this is the time to revisit the high weighting topics that you've already covered. And that includes infection, endocrine system, CNS, and cardiovascular system. And what I'm going to do is in this video, I'm going to include almost an hour long video on sexual health and infection, and we go through some GPhC style questions on infection that you'll find quite useful. So let's get that started, and I will see you. So I'm going to skip tomorrow because this today covers both, and I'll see you the day after. And this recording will be available by the end of this evening. So let's get started with the first question. Bear with me, I'm going to put the poll function up. So please use the poll function rather than putting the answer in the chat. Okay, this question is, which of the following antibiotics is most effective against Pseudomonas aeruginosa? I know a lot of people said to me they struggle with spectrum of activity, and this is the reason why a lot of the questions I'm going to ask you today will focus on spectrum of activity and different choices. Okay, let's share the answer from the first poll. So the majority of you have voted piperacillin tazobactam. In terms of Pseudomonas aeruginosa, is it a gram-positive or a gram-negative organism? Negative, absolutely, Khadija. And in terms of what sorts of infections does it tend to cause? What kind of infections do you see Pseudomonas being involved in and implicated in? It can, yeah. So your more complicated cases of urinary tract infections. When it comes to pneumonia, there's specific types of pneumonias that it tends to be more prominent in. So the more prominent type of pneumonia is hospital-acquired pneumonia. So it tends to cause hospital-acquired pneumonia. As someone just put in the chat, absolutely. It tends to cause hospital-acquired pneumonia a lot more. In cases of HAP, you'll tend to see Pseudomonas being a common culprit. So the correct answer for this was C, piperacillin tazobactam. It has the best activity when it comes to Pseudomonas. Most of the agents don't have activity against Pseudomonas, and ceftriaxone has very minimal activity. It's like questionable. Like you will never use it for a Pseudomonas infection. So your best option here is C, piperacillin tazobactam. In terms of people mentioning skin, yes, it tends to, it used to cause a lot of cases of diabetic foot infections when I used to see these patients in practice. I used to run a clinic with a podiatrist for patients with diabetic foot infections. And for the more complicated, so the moderate to severe cases, you will see Pseudomonas quite often being what we found when we took a swab of the area. Okay, let's move on to the next question. A patient with penicillin allergies requires an antibiotic for an MRSA bacterial infection. Which of the following would be the most suitable? Jesse, in terms of yours, it's a broad spectrum. So piperacillin tazobactam is a broad spectrum agent. So when you use the term narrow spectrum or broad spectrum, you're really talking about all the organisms that they cover, and it's a broad spectrum antibiotic, and it does have coverage against Pseudomonas. So I hope that helps you out. So like you wouldn't normally say something has a narrow spectrum to one bacteria specifically. You'll say an agent has a narrow spectrum activity because it only covers a few, but it's generally a very broad spectrum antibiotic. You quite often will see Pip-Taz being given patients with sepsis of unknown origin because it's just so broad. Okay, so for this, let's say, for example, this, I could even make it more specific. So if we're saying for this patient in particular, the patient has infective endocarditis, what would you say would be the most suitable option? Infective endocarditis, a penicillin allergy, and MRSA infection. MRSA is causing the infective endocarditis. Which option would you go for? From the options that we have. So what would we go for? Vancomycin, yes, absolutely. You'd go for vancomycin for infective endocarditis. The reason why not meropenem? Well, meropenem's activity, you've got a patient with a penicillin allergy, so you need to know the nature of that penicillin allergy. That's one of the important things because meropenem is a beta-lactam antibiotic, and vancomycin has more prominent MRSA coverage. Let's move on to the next question. So for that question, the answer was vancomycin. Which of the following antibiotics is a macrolide and it's effective against atypical pathogens like Mycoplasma pneumoniae? Okay, let's share the results. The majority of you put down C, which is azithromycin, which is correct. Azithromycin is a macrolide, and it also has activity against atypical organisms. Can anyone name the atypical organisms that can commonly cause, let's say a respiratory tract infection, or just name me any. What are atypical organisms, first of all? No, not Staphylococcus. Mycoplasma pneumonia here, yes. Cheeky. No, not to do with commonly. So this is, they don't gram stain. Absolutely, Carla. So they don't gram stain. So if they do not gram stain, do you think Streptococcus is one of them? What do we think? No. And that's because Streptococcus we know is what? Gram negative or positive? Positive, yes. So Streptococcus is a well-known gram-positive organism. So if it's neither gram-positive nor gram-negative, this is where it's called atypical. The term atypical, some microbiologists don't like the term atypical because it used to be atypical a very long time ago because it didn't used to cause infections very commonly, but it's much more prominent now than it was before because we have ways to identify it. So what microbiologists like to call it nowadays, they like to call it non-culturable because what that means is that it's clearly saying to you it doesn't gram stain. So Mycoplasma pneumoniae was one of the examples. Legionella pneumophila, which a reader did say. So yes, Legionella was one of them. Is knowing gram-positive and negative essential for the exam? Well, it's very difficult to say, but what we do know is like this sort of question in particular, this sort of question came up in the sample paper. So the sample paper for this year, there was a question asking about the fact that you have to identify what causes a patient's exacerbation of their COPD, and an atypical organism is not implicated. So they wanted you to know what atypical organisms are. And this is why I think it's very important. And I spend a lot of time teaching you this because it came up in the sample paper. What I would say is the question won't be extremely difficult. The answer for that particular sample paper was Streptococcus pneumoniae, which most people get right when I ask so when I do sessions where I go through sample questions, like 96% of the audience get the question right. But it does tell you that they want you to know spectrum of activity to a certain extent. Okay, so yeah, so let's go through. We've got Legionella pneumophila, Mycoplasma pneumoniae, and we also got chlamydia, which someone gave as a direct message. I wish you shared it with everyone. Chlamydia pneumoniae is your third example. Yeah, so these are the three most common. Jesse, can I double check about the MRSA penicillin, please? Do we normally go for vanc or gentamicin, as both of them have? Gentamicin and vancomycin are useful options. Are you referring to, Jesse, are you referring to infective endocarditis? Or just generally? These have been very busy questions. I've got a lot of people just complaining that they can't get into the session because it's full. So if you're talking about generally, um, if if a patient has MRSA, in many cases, many trusts would use vancomycin and will have the addition of a low dose of gentamicin alongside it. Does everyone want me to go through that in a lot of detail, or do you think it's just going to confuse a lot of people of why we do that for infective endocarditis? What do you think? Do you want me to go through it? Because I wasn't planning on. Yes, okay. So when it comes to infective endocarditis for blind treatment, you can either use amoxicillin. It really depends on whether it's prosthetic valve or native valve. I'm not going to go through that in a bit more detail, but I will go through. I won't go through that in a lot of detail, but I'll go through why the treatment options are there. So amoxicillin gives you good coverage against the most common causative organisms of infective endocarditis. In many cases, it's caused by Staphylococcus aureus. What you can also use if MRSA is implicated, you can use vancomycin and you can use a low dose of gentamicin. So can someone tell me how vancomycin works? First of all, why would you not want to give vancomycin and gentamicin together generally? Can someone tell me that? They both can cause ototoxicity. They can irreversibly damage a patient's hearing, and they're both nephrotoxic. So generally, we don't want to give it, but this is a circumstance where we want to consider it. So why do we think how? Let's go through it in detail. How does vancomycin work? What's its It inhibits cell wall synthesis. How does gentamicin work? You've already got it. Yeah. So gentamicin works by inhibiting protein synthesis. So gentamicin needs to make its way past the cell wall to get into the cell to bind to the ribosome and inhibit protein synthesis. If you give them both together, they work synergistically. The vancomycin sort of opens the door by inhibiting cell wall synthesis and making it more permeable, and the gentamicin goes in, attaches to the ribosomes, and can inhibit protein synthesis. So that's why they're used together. You give vancomycin, and you'll see in the guidance, in the national guidance, use a low dose of gentamicin, and that's because you want to limit the possibility of ototoxicity and nephrotoxicity. Okay, let's move on to the next question. What is the primary mechanism of action of beta-lactam antibiotics? By the way, whilst you're answering this question, we have a session on the 10th of June with Morph, and you can tell as many friends about it as possible, as we have a capacity of 300 for that session. So we're not going to have the problem of limited seats for that. So I've just popped that in the chat. That's going to be an hour and a half, that session on the 10th, and we're going to go through quite a lot of clinical questions, so it would be good for you to attend. Okay. Okay. So the majority of you put down inhibiting cell wall synthesis, which is the correct answer. So it doesn't disrupt cell membrane integrity. It inhibits cell wall synthesis. And by doing so, the structural support for the cell is taken away. Yes, so it's cell wall synthesis, not cell membrane. Most antibiotics have an effect on the cell wall rather than the cell membrane. Which antibiotic is known for its activity against anaerobic organisms and is used to treat Clostridium difficile infections? Someone sent a private question about do beta-lactams have the same mechanism of action as vancomycin, which is a great question. So they don't have the same mechanism of action. They work in different ways, but they ultimately do the same thing. So they ultimately inhibit cell wall synthesis, but they do this via different mechanisms. Great question, Nabil. Are macrolides generally the best for atypical pathogens? Well, you've got three options when it comes to atypical pathogens in terms of classes of antibiotics. Does anyone know what they are? Anyone? Okay, I didn't know this abbreviation. Fluoroquinolones, tetracyclines, and macrolides are your three options. Absolutely. So fluoroquinolones, what's the A in fact? That's what I'm missing. I feel like I'm missing something. So fluoroquinolones, like ciprofloxacin and levofloxacin, tetracyclines, particularly doxycycline. Doxycycline is not all tetracyclines have good activity against atypicals. So there's azithromycin and macrolides. Now, it's obviously dependent on, you may, in most cases, you're not going to use the fluoroquinolone as a first line, and that's because of its safety profile. Um, so, so you'd either use a macrolide, what am I talking about? I think someone's just caught me in the middle of a sentence. All of these antibiotics cover atypical organisms. So do you know when we talked about non-culturable or atypical organisms? All of these, so fluoroquinolones, macrolides, and tetracyclines. In particular, just remember doxycycline, because not all of them cover atypical in the tetracycline family. So yeah, these cover your atypical organisms. So in most cases, it'd be either between a macrolide or a tetracycline like doxycycline, and a fluoroquinolone if you can't use those. Okay, let's share the answer. Most of you put down fidaxomicin, which is the correct answer. What else treats C. difficile? We've gone through this in a lot of detail. So vancomycin and always orally. Never IV. Vancomycin, never IV. It won't work. Why won't it work? Does anyone remember? It doesn't, yeah, it can't cross the gut lining well, so it's too large as a molecule. Okay, let's move on to the next question. Which of the following antibiotics, come on, you're gonna get this. Which of the following antibiotics should not be used in children at the age of 12 because of risk of permanent teeth discoloration? Let me answer the question in the chat. Does it need to be taken only orally? So for vancomycin, only orally. For fidaxomicin, only orally. There's only one IV option you can use. Does anyone know what that is? And that's only in life-threatening cases of C. difficile. IV metronidazole can be used alongside oral vancomycin in life-threatening cases only. And these three options are the only three options that you have in terms of treatment, in terms of national guidelines. So these guidelines are nationally. I know some local trusts, so some of the trainee pharmacists that I mentor were telling me that in some of the local trusts, particularly, I believe it was in Glasgow, they still use oral metronidazole, but the reason is it's oral metronidazole still effective. It's just not as effective as vancomycin. So some trusts haven't moved towards that. In terms of the exam, I want you to remember only these three. Someone asked again, can you repeat the three options for C. difficile? So oral vancomycin, oral fidaxomicin, and IV metronidazole. IV metronidazole is only used in life-threatening cases alongside oral vancomycin. Okay, let's share the response from this question. Doxycycline, yes, doxycycline should not be used in children under the age of 12. Moving on to the next question. Which of the following antibiotics works by inhibiting protein synthesis by binding to the 50S ribosomal subunit? Which antibiotic? Okay, let's share the results. So the correct answer for this was C, erythromycin, because it's a macrolide, and macrolides work by inhibiting protein synthesis. It was not ciprofloxacin, because ciprofloxacin works by inhibiting DNA synthesis, by inhibiting DNA gyrase. Okay, let's move on to the next question. The next question is, which antibiotic is effective against both gram-positive and gram-negative bacteria and is often used as a broad-spectrum empirical treatment for severe infections? So this, I know people are going to struggle with it because it's not very often people ask you about how broad the spectrum of activity is for a particular agent. There's a huge hint, and that's it's active against both. That should rule out some options for you. Oh my God. I've never had a question so split. We've got like 20% of people voting per question. So this is just a testament to how much people hate learning spectrum of activity and microbiology. Okay, shall we share the answers? This is these results will be shocking to you. So 32% for A, 18% for B, 17% for C, 15% for D, and for E, we've got 18% as well. So can anyone tell me confidently which of these antibiotics only works against one side? So either gram-positive or gram-negative. Which one? Which ones? Vancomycin, linezolid only work against gram-positive organisms. Flucloxacillin only works against gram-positive organisms. In terms of see, amikacin is the only one that mostly works against gram-negative and has activity against Staph aureus only. So it's if you want the broader spectrum from all of the options that you go for over here, your broader spectrum is your cefuroxime. Your cefuroxime is the only one that gives you a fairly broad spectrum of activity where you can use it for severe infections, where you want coverage of multiple organisms on both ends. In terms of the amikacin works against all gram-negatives and only Staph aureus. For the vancomycin, only gram-positive. So it's only gram-positive for the vancomycin, only gram-positive for the linezolid, only gram-positive for flucloxacillin. Very interesting responses there. But hopefully you learned a lot from just going through over that one question. Okay, this is where I think people will struggle. Let's go through some sexual health HIV questions. So a 52-year-old female patient. Let's go back. Is everyone lost in terms of that previous question? Anyone else? Just bear with me. I'm sorry. Yeah, a lot of people are confused. Okay. So what you want here is you want an antibiotic that has the broader spectrum of activity from these options. Flucloxacillin, linezolid, and vancomycin only work against gram-positive organisms. So this question says it has to be effective against both gram-positive and gram-negative infections, It has to have a broad spectrum activity for empirical treatment for severe infections. So you want the broadest spectrum agent possible. The only options that work on both sides in terms of gram-positive and gram-negative are cefuroxime and amikacin. The only limitation with the amikacin is it only works against. I'm going to go back to that HIV question. Don't worry. I just want to go through this with everyone. The cefuroxime is the only one that works on both ends and has good activity on many gram-positive and gram-negative organisms on both ends. So if you want to use it, let me give you some just names of organisms. So cefuroxime, it will have activity against your Staph aureus. It'll have activity against beta hemolytic strep that can cause foot infections. It'll have activity against Streptococcus pneumoniae, and then it'll have activity against many gram-negative organisms as well. So the broader spectrum agent over here is the cefuroxime. Okay, let's launch the poll. Do you mean beta? I'm guessing you mean beta-lactam antibiotics will be the best option in these types of questions. It depends. It depends on what your, as in these. You can't say broadly speaking for these types of questions because they can ask you about any infection. But if we're talking about what type of questions are you talking about? Just generally like the broader spectrum agent. It's I wouldn't say it's very difficult for me to say. Like if you're talking about sepsis of unknown origin and the most broad spectrum agent from options, if you had options, could be meropenem or piperacillin tazobactam because it's broader than cefuroxime. So it's not a one size fits all. I would say that's one of the most important things I would say. So it's not a one size fits all for these. Okay, so for this question, the correct answer is atazanavir. Has anyone gone over the life cycle of HIV? Unfortunately, I'm not gonna go through it today because it will probably take me 20 minutes just to explain. But is anyone familiar with the life cycle of HIV? Don't be shy to say no. I can always no. I can always put in. See, you may get a question that asks you about where an antiretroviral belongs. But I mean, it would probably be one, if anything. Like it's not going to be heavily covered in the assessment. So maybe this is why I don't go through it in a huge amount of detail, but only to the extent of what you may need to know. If anyone does want me to go through it in a subsequent session, I'm more than happy to put something together. Okay, let's move on to the next. Okay, Rahila, we've already got one person taking up my offer. So two. Okay, I can put something together. I'm presuming everyone follows the MicroPharm Instagram page because that's where I advertise subsequent sessions. If you do, then that's where I will advertise the next session. So let me put I'll put some. I really want to like how keen would people be on like a daily quiz session? Like like let's say 4 or 5 sessions leading up to, a week leading up to the exam. Because I can, yeah, I honestly didn't think people would. Okay, I honestly didn't think that there would get that many takers. Okay, perfect. Okay, so let's go through this question. This question is going through entry inhibitors. And I know I can tell a lot of people are struggling with HIV topics. So I'll try to cover this at least as a 15-minute session in subsequent webinars. So in terms of the correct answer here, it's D, Maraviroc. What entry inhibitors do is they prevent the HIV virion from making its way into the cell and hijacking the DNA synthesis within this cell. Okay, this is a good question. A patient diagnosed with tuberculosis should be treated with which combination of medications? Yeah, so as I said, I just mentioned that about 10 minutes ago, Jel. In terms of HIV stuff, if anything, you may get a question on classifying antiretrovirals or something to that extent, or maybe an important factor about an antiretroviral, but not that's if anything, it'd be one question. It is a specialist topic. In terms of is anyone part of the NHS England curriculum for teaching? Has anyone been taught by me as part of an NHS England session? Because I teach for the NHS England curriculum. I cover the Midlands area. So I cover the Midlands area for NHS England. And I've taught about, I'd say probably 150 trainees in that area. So you can see in that, like NHS England told me to cover was it a 1 hour? I did a whole 1 hour session on just sexual health. But I would say, that was more complex than you needed to. That was more complex than you needed to know for the assessment, but it gives you a good flavor of what to consider for sexual health. Yes, I was just going to say that, Maria. So RIPE is your acronym for treatment, and 100% of the people got this right, so it's really good to see. So RIPE is your acronym for treatment for RIPE is your acronym for treatment of tuberculosis. So it's rifampicin, isoniazid, pyrazinamide, ethambutol. I have some more little nuggets of useful information. Let me just pull up the slides. The answer for the last question was D, Maraviroc. Okay, so let me just bear with me. I'm gonna add more to say about tuberculosis, but let's see if I can get the slides up. Just bear with me. Okay. Just bear with me. I'm gonna pull. Okay, so in terms of more things that you need to consider when it comes to tuberculosis, RIP is something that you need to consider. What is it about the rifampicin, isoniazid, and pyrazinamide that can be grouped together? Does anyone know? What can they all cause? They can all cause hepatotoxicity. Yes, RIP. The rifampicin, anything that's important to consider about the rifampicin when it comes to counseling? Yes, they can cause orange-red discoloration of your secretions. This is particularly, you have to be mindful if someone wears contact lenses as well, it can stain the contact lenses. Isoniazid can cause peripheral neuropathy. And what would you give to patients to prevent the peripheral neuropathy? Pyridoxine, which is vitamin B6, absolutely. And ethambutol can cause ocular toxicity, so it can cause visual disturbances. So these are all the points that you need to, the important points that you need to know about tuberculosis. One thing that you also need to know is that its management is in two stages. You've got the initial phase, and then you've got the continuation phase. What would you give during the initial phase? And for how long, generally? There's no slide for this, Faithful. I'm just saying this off the top of my head. Someone asked about this slide. So RIPE, yeah. So rifampicin, isoniazid, pyrazinamide, ethambutol, you give for 2 months, and then you've got the continuation phase, which is isoniazid and rifampicin, which you give for 4 months, and that 6 months is your treatment. You go aggressive for the first 2 months because you want to rapidly depopulate the mycobacterium, and you want to completely just get rid of it, get rid of as much of it as possible. It's very hard to treat. And what they say is that surface is very hardy, and what that means is it's just very hard to penetrate the surface of Mycobacterium tuberculosis. So because it's so difficult to treat, you want to treat it as aggressively as possible in the first 2 months. Okay, that's today's session done. Hopefully you found that useful. I've put some useful links in the chat. One thing I've also put is, can you just complete the feedback form, please? It'll just take you a minute, and it'll be really useful for me to know. And if you've got any feedback for other members that you want to share with other people so that they actually join the sessions, subsequent sessions, that will be really useful for me as well. I'll start to put some more sessions together. In terms of sessions, what's the earliest people can do? Or is 7 p.m. like the earliest? In terms of the session recordings, they go to members only, unfortunately.